Hi, today it's my pleasure to talk to you about assessing cardiovascular risk with a low-carb, high-fat lifestyle. I'm Dr. Bret Scher, and let's be honest, a lot of us in the audience, if you're a clinician, you're either already using low-carb to help your patients or you're curious about using low-carb, but regardless, you might have some concerns about what it means for you to maybe be outside of what the norm is for medical practice, outside of what your other colleagues are doing. And what does that mean for you from a reputation standpoint or a legal standpoint? And how do you know for sure you're helping more than you're hurting your patients? I mean, that's what it's all about. That's what a lot of us lay awake at night thinking about. And if you're not a clinician, if you're an individual, you probably have the same thoughts for yourself or for your loved ones. If you want to follow a low-carb lifestyle, but it's not really being talked about by your doctor or the general medical community, how do you know you're actually helping yourself? And the biggest concern about low-carb lifestyles is cardiovascular risk. And that's why I think it's so important to have an open and honest discussion about what we know and what we don't know about assessing cardiovascular risk with a low-carb lifestyle. So for the next 30 minutes, I'm going to show you the one and only slide you really need to know about assessing cardiovascular risk with a low-carb lifestyle. We're going to talk about the over-reliance of LDL cholesterol and how the medical community relying too much on LDL has hurt us more than it's helped us. But also, I want to explore a little bit about being honest about what we know and what we don't know about the risks and benefits of LDL. And maybe approach things from a contrary perspective from the low-carb community, just to make sure we're not making things overly simplistic. And I want to talk about in the structure of how to kind of filter this population-based research and bring it down to the individual level, because that's what we cared about. What does it mean for you? What does it mean for me? What does it mean for our patients? So with that, let's get started. First, my disclosures: I don't have any financial ties to pharmaceutical, diagnostic, or medical device companies. I am the medical director at dietdoctor.com. We're the largest online low-carb website where we provide mostly free material, and we're supported by an optional membership. I see telemedicine consults at lowcarbcardiologist.com, and I do get some book royalties. Now, as clinicians or as individuals, this is our goal, right? These are the images that I think of when I think of what I want for myself and what I want for my patients and my clients, and hopefully it's the same for you. We want to live healthy, vibrant lives, healthy in mind, healthy in body, healthy in soul, doing the things we want to do. Nobody comes to me as a patient saying, I want to have a heart attack a year later than I otherwise would have. I want to delay my heart attack, or I want to get cancer instead of a heart attack. Right? People don't think in those ways. But when we focus so much on one disease process, sometimes that seems like it's what we're promoting. But this is the slide I want to think about, and I want you to think about with your patients. What is giving your patient, or what is giving you as an individual, the best shot to live the vibrant, healthy, energetic life that you want? And let's face it, this isn't it. Right? This dietary advice of eat less, low fat, that's all you need to do to be healthy, doesn't work. And it hasn't worked since 1977, when the dietary guidelines were put into place, and shortly thereafter our obesity and diabetes rates skyrocketed. And it's not that one necessarily caused the other, but certainly one did not prevent the other, and it put in place the lifestyle to allow ourselves to become overweight and to become diabetic and to become chronically ill. And that's because the low-fat movement, the low-fat focus, doesn't take into account that we are emotional human beings. We have feelings, we have thoughts, we have cravings, and we feel hunger. Any dietary advice that doesn't address hunger, that doesn't address how we feel, isn't going to work. And that's unfortunately taken us 50 years to learn, and some people are still learning it. But if only there was another way, right? If only there was another way. Well, luckily there is. We can address hunger. We can address cravings with healthy, low carb, moderate protein, higher fat diets that hit all the points we need to feel good about what we're eating, to feel good about how we're feeling. But part of the problem is when people see slides like this, they see the bacon, they see the egg yolk, and right away they think, oh no. But there are other ways, right? If you presented this slide as a low-carb lifestyle, I don't think anybody would have any objections about a diet like this. So a lot of it depends on how you phrase it and how you think about it. And that is the disconnect, right? Because this provides all the nutrients you need, provides tons of healthy fats and the proteins without any of the carbs that stimulate hunger, which increase our insulin. And so I'm sure you've heard so much this weekend already about the benefits of low carb lifestyles. And here are a number of the benefits. When I say I'm going to show you the one and only slide you need to see for understanding cardiovascular risk on a low carb lifestyle, this is it. And in fact, this may be the only slide you need to see to understand cardiovascular risk, period, whether you're on a low carb lifestyle or not. And what you can see is on the left-hand side of this slide, so first, to lay it out, this is a comparison of a very low carbohydrate ketogenic diet, the dark blue or dark gray, versus a low fat diet, the light blue, in a 12-week trial run by Dr. Volek. And what he showed in only 12 weeks, the body mass went down by more on the very low carb ketogenic diet, but more importantly, not just the body mass, the abdominal fat mass. And we know from observational research that the abdominal fat is more likely to be related to cardiovascular disease and cancer and other comorbid conditions than just body mass in general. So the abdominal fat is much more important, and the ketogenic diet improves that much more than a low fat diet. And then next, look at the triglycerides and the HDL. There is nothing that can improve triglycerides and HDL and the triglyceride to HDL ratio to this degree. In 20 years of medical practice, I haven't seen anything clinically useful that can impact it like that. And to be able to lower the triglyceride to HDL ratio that dramatically, there's one thing and one thing only that I've seen, and that's a very low carb, higher fat ketogenic diet. Now, just take a second to talk about HDL, because a lot of people have sort of been hating on HDL lately. In fact, some people have been saying we should stop measuring HDL because drug trials to increase HDL don't improve cardiovascular outcomes. A recent drug trial infusing ApoA1, which is basically, you could think of it as infusing HDL, doesn't improve cardiovascular outcomes. So if you think about it from that standpoint, that drugs that increase HDL don't improve things, and if your lifestyle that you believe in lowers HDL or doesn't raise HDL, it makes sense that you would jump on that and say HDL is not important anymore because that fits your cognitive bias. But let's think about this for a second. The evidence we have for HDL is that if you have a naturally low HDL, you are at higher risk of cardiovascular disease. So what's the logical corollary? Well, don't have naturally low HDL, right? It doesn't mean trying to increase it with drugs. It doesn't mean trying to manipulate it. It means don't have naturally low HDL. And what's the best way to do that? Well, as you can see on this slide, a very low carb ketogenic diet and not a low fat diet is the best way to do that. So the triglyceride to HDL ratio is correlated with extent of cardiovascular disease and early onset cardiovascular disease, and the very low carb ketogenic diet is a great way to improve that. Next, how about the ApoB to ApoA1 ratio? You can think of that as sort of a fancy LDL to HDL ratio. It's better than LDL, it's better than HDL, and you put that ratio together. In the PURE study, which was a large 170,000 person observational study, they found that the ApoB to ApoA1 ratio was the most predictive marker for cardiovascular disease. And what does a very low carb diet do? It reduces that ApoB to ApoA1 ratio, whereas the low fat diet increases it. Next, we have the small dense LDL, which I'm going to talk quite a bit about, but the low carb diet reduces the small dense LDL, which is associated with increased risk of cardiovascular disease. The more small dense LDL you have, observational trials show the more likely you are to develop cardiovascular disease. And then, of course, glucose and insulin reduce dramatically compared to the low fat diet. So not only does the low fat diet not work in terms of a hunger and a satiety, and helping you eat in a healthy manner, it doesn't work as well as the low carb ketogenic diet for improving all these cardiovascular risk factors. So when it comes to assessing cardiovascular risk, this is the go-to slide. But of course, there's a concern, right? The concern is the fat and the cholesterol, because we've been taught for decades that dietary fat increases cholesterol in our body, increases LDL, which increases cardiovascular risk. In fact, there was a cardiologist recently who posted an editorial saying, I implore people not to try a ketogenic diet. Implore people. The language used was so strong and so impressive. And why? Because your LDL might go up. Ignoring all the potential benefits, ignoring everything I just showed you on this slide, not even mentioning this, but because your LDL might go up, I implore people not to try the ketogenic diet. So it puts us in this position where we're sort of conflicted, right? We have this would you rather situation. So I have a young son who loves to play this game of would you rather. So when I come home, frequently the first thing he'll do is he'll run up to me and he'll say, Daddy, would you rather get eaten by a shark or bitten 10 times by a rattlesnake? To which, no one wants to walk into an image like this thinking about that. So I said, hang on. How about you ask me, how was your day, Daddy? To which he'll say, okay, Daddy, how was your day? Would you rather get eaten by a shark or bitten 10 times by a rattlesnake? And I say, listen, how about we start with, would you rather go mountain biking in the forest with the sun peeking through the trees as you hear the wheels rolling over the leaves? Or would you rather go running on the beach where all you hear is the wave? Before I can even finish, he's like off to torment his brother because I don't want to play his game. But you can see the point being that as clinicians, sometimes we feel like we're in this battle of would you rather improve metabolic health and lose weight, improve all those markers I showed you before, or have normal LDL. And it's this game of would you rather. But it doesn't have to be that way. So the first question we have to ask is LDL really a concern with a low carb lifestyle? And the answer is no. Well, probably not. And let's get into that a little bit. So here's a meta-analysis of 1,600 people in 8 randomized controlled trials looking at the impact on carbohydrate-restricted diets. And at 6, 12, and 24 months, there was no difference in the carb-restricted group versus the control group in their LDL cholesterol. So this trial alone shows you that you don't have to have that would you rather game. At 6, 12, and 24 months, there was no difference in these 1,600 people. And then here's another one. Of course, the Verta Health study, 1 year of a ketogenic diet, there was no change in the ApoB. So I'm using ApoB now instead of LDL-C. And a quick definition, you can think of ApoB as the better marker. It's a better risk factor marker than just the LDL-C. LDL-C being the amount of LDL in all of your body and all the LDL particles, the total amount of cholesterol. Whereas the ApoB is specifically the number of LDL particles, IDL particles, VLDL particles, and lipoprotein(a) particles. It's unique to those particles, but shows you the number of particles, which is a better measurement, right? So think of it as a better LDL. So there's no change in ApoB in 1 year. The A1C decreased by 20%, the HDL increased, and 94% reduced or eliminated insulin. Is this what this cardiologist was so worried about, imploring people to not try the ketogenic diet because of the potential risk of your LDL? I sure hope not. And here's that same study. They evaluated the 10-year calculated cardiovascular risk score, and it decreased by 12%. But this is despite the LDL-C increasing by 10%. So let's pause for a second. The LDL-C increased by 10%, but it was the same study I just showed you where the ApoB didn't change at all. So that shows you once again how this over-reliance on LDL cholesterol is probably harming us more than it's helping us because the overall cardiovascular risk decreased. And how did it happen? Well, like I said, no change in ApoB. The small LDL decreased by 20%. And so here you can see a study, an observational study. On the left side, you can see the risk of cardiovascular disease as put out by the quartile of small dense LDL. And the higher the small dense LDL, the higher the risk. The lower the small dense LDL, the lower the risk. Whereas on the right side, it's the same graph, but for the larger LDL, not the small dense. And you can see the curves don't separate. So it's clear if you wanted to choose, if you could choose whether you had small LDL or large LDL, you would clearly choose large LDL. We're going to revisit some more of this data in a little bit, but suffice it to say, reducing small dense LDL is a good thing when you do it with this type of lifestyle, and that would prove to be beneficial most likely. How else did they do it? They also decreased their APO to A1 ratio, which, as I mentioned in the PURE study, was the most predictive of cardiovascular disease. They reduced their triglyceride to HDL ratio by almost 30% and reduced their large VLDL by almost 40%. So that's how you reduce cardiovascular risk, even if the LDL-C goes up. And that's why this over-reliance on LDL-C has led us down the wrong path. And here's that slide from before, showing everything that the Verta Health trial showed, all those markers that improve, that reduce your cardiovascular risk. But there is this group of hyper-responders, right? We've heard a lot about it, where the LDL doesn't just go up 10%, but it can go up 50%, 100%. It can skyrocket to levels that give doctors heart attacks and make doctors worry about familial hypercholesterolemia, or worried that this patient's going to drop dead because the LDL is so ridiculously high. What do we do about it? Well, the concern there is that LDL is causal for heart disease, right? Or is it LDL is causal for heart disease? Let's look at that again. LDL is causal for heart disease, or LDL is causal for heart disease? Kind of hard to figure out where the truth lies on this, because so many in the lipidology community say LDL is causal for heart disease, period. But when you really start to think about it, I think you have to question, is it really causal? And this is a paper that just came out from the European Society of Cardiology. So I want everybody to memorize this slide, okay? Just kidding. There's obviously too much here to memorize. But if you can see, there's an LDL, it says LDL transcytosis or influx to the arterial endothelium. And this is what they use as their example of how LDL is causal for heart disease. But then you look at everything else involved, the genetic determinants of arterial wall biology, hypertension, low shear stress, systemic inflammation, smoking, diabetes, oxidative stress, proteolysis, lipolysis, aggregation, circulating monocytes, all these other things, pro-inflammatory mediators, all these things are involved. So how can you say LDL is causal for heart disease when it also requires all of these other components? So to me, it doesn't just make sense. And we have studies that show not all LDL are the same. So this is way back from the 80s, the Framingham Heart Study Evaluation, which was one of the first studies to show that LDL is associated with increased cardiovascular risk. But what I love about this slide, one of my favorite slides, is it also correlates that to HDL. And so as you can see, as HDL increases to 85, it didn't matter what your LDL was, whether it was 100 or 220, your risk of cardiovascular disease was the same. Now, as you went down to 65, there was a slight change in your cardiovascular risk with increasing LDL. And then when you went down to 45 and 25, that's really when you saw the increased risk. But also look, if your LDL was 100, as you went down on your HDL, your increased risk as well. So a slide like this says LDL is involved, but it clearly says LDL is not everything. So to say LDL is causal and the one factor we need to focus on, again, does us more harm than good. And here's another example of this. The 4S trial, which was a trial of simvastatin intervention in people who have already had heart disease. And this was the one statin trial that showed the greatest benefit, a 4% absolute risk reduction, the greatest benefit of any statin trial ever done, that it hasn't been replicated. But what it shows, if you look on the graph, the white squares are the people with this lipid triad, so low HDL, high triglycerides, and high LDL, who are treated with a statin. And there's a clear difference between the squares, not treated, and the white circles, who were treated. But then let's look at the black lines. The black lines were the people who had isolated elevated LDL. So their HDL was not low, their triglycerides were not high, and there's no difference between the treatment group and the non-treatment group in that study. So it's clear that LDL is not the whole picture. So here, many of you have hopefully been able to enjoy some time with Dr. Brian Lenskis, and this is one of my favorite pictures with Dr. Andros Einfeld and my kids. You know, I'm 5'5", my wife's 5'2", so no secret we don't exactly have tall kids, but compared to Dr. Einfeld, they certainly barely come up to his waist. But what is the point? I don't show this to embarrass my colleague here, Dr. Einfeld from Diet Doctor, but what I show this is because of this concept. Dr. Lenskis, Dr. Einfeld, when you're around them, they're the type of people that make you think you can accomplish anything. They're the type of people that make any problem something you can fix. They're the type of people that you want to be around because you feel better when you're around them. And the same is true for your LDL cholesterol. A little bit of a reach maybe, but I'm getting somewhere with this. The LDL cholesterol, the company it keeps matters, right? So these trials show the company it keeps with your HDL triglycerides makes a difference. And just treating all LDL the same and over-relying on LDL does us more harm than good, especially for people following a low-carb lifestyle, because we don't fit the normal population, right? Kind of nice to say we're not normal, but we don't fit the normal population. And this is part of the nuance of science that comes from taking these population-based studies and try and filter it down to the individual. What does it mean for me? Or what does it mean for the patient right in front of me? Or what does it mean for you? And that's part of a disconnect that we have when we talk about population studies that are based on people eating low-fat food that are metabolically unhealthy. And so you want to surround yourself with the people that make you better, right? And as this study showed, where the LDL, how the LDL is associated with HDL makes a difference. And so when it gets to LDL is causal for heart disease, LDL is involved in heart disease, no question about it. And if you lower LDL dramatically, you could potentially lower your risk for cardiovascular disease. But what does it mean if you still have the hypertension, the low shear stress, the systemic inflammation, the smoking, the diabetes, the oxidative stress? If all those things are still there, you're not completely eliminating your risk. So it truly is a whole picture. And it's so easy to say, oh, you just have to address all these things. But it might not always be so easy to address all of them. And here's maybe where I'm going to stand out from the crowd a little bit. Because we have to say, okay, LDL is not everything. Right? We know that. But what don't we know? Where are the gaps in our knowledge? Where are the questions that we still have to ask ourselves? And I don't bring up this next point to be overly complicated. I bring it up to make sure we're not overly simplistic. All right. So here are some of the counter arguments to LDL doesn't matter. Can we eliminate vascular injury and inflammation altogether? Right? Because as long as there's vascular injury and inflammation, it appears that LDL plays a role. Maybe it's an immune response, a healing response, but that can get out of control and cause plaque buildup and deposition. So if we can eliminate vascular injury and inflammation, that's a pretty good spot to be in where maybe LDL doesn't matter. But we can certainly reduce it. The question is, can we ever eliminate it? We probably wouldn't want to. I mean, inflammation is a normal part of our body. We need it, right? We talk about it in such a negative way, but we need it. And vascular injury to small degrees may always be happening. So we have to be careful about saying, oh, low carb diet eliminates inflammation and vascular injury, so we don't have to worry about it. Not always the case. I see a lot of patients coming to me saying, I'm a hyper responder. I don't need to worry about LDL, right? But maybe they have a chronic inflammatory condition like psoriasis or a chronic arthritis or a Sjogren's syndrome or some sort of inflammatory disease that says, wait, maybe you have to be a little more careful about this. Or maybe their CRP isn't as low as we would like it. So we really have to be careful about saying we can eliminate inflammation. There's also observational trials showing that elderly patients with higher LDL live longer. Well, observational trials, right? I'm very critical about nutritional epidemiology and observational trials. And we also have to have a critical eye for any type of observational studies. Does this prove that LDL is protective? No, certainly doesn't. It suggests that LDL is not harmful for these people. So what makes them different? Is there a selection bias? Did people who are more susceptible to LDL, do they sort of get excluded from these trials because they already had pre-existing heart disease? Or did they not survive to this part? There are questions about observational trials that we need to keep asking. And treating elderly with statins doesn't have the same benefit as treating younger people. Okay, is that again selection bias? Or is it have something to do with the duration of the treatment? Again, not to make this overly complicated, but making sure we don't make it overly simplistic. And LDL has a purpose. Clearly it does. It's involved in energy transport. It's involved in immune response. It's involved in fat-soluble vitamins. But where's the cutoff, right? If lowering LDL can be potentially harmful if it has a purpose, at what cutoff point? And there are some studies showing that lowering it all the way down to 50 may not have abnormal consequences at 2 years, at 3 years, right? So not very reassuring for 20, 30-year potential data. But LDL has a purpose, but we don't know where that cutoff is of where the requirement is. Next, no mortality benefit for primary prevention LDL lowering. So that's mostly true. And this, again, comes down to picking the right people, right? If you take this population-based study, and most people with primary prevention aren't going to benefit from LDL lowering, but that's not to say there isn't a subset that will. So making sure if you or the patient you're discussing is in that subset who might, low carb or not low carb. This is part of the nuance of taking the population-based data and boiling it down to how does it apply to the person in front of me. And then the comment that large LDL is benign. I would say large LDL is certainly less dangerous. Is it completely benign? Well, when I showed this slide once before, it certainly, according to this one, appears pretty benign. But here's another one. A little bit complicated, but if you look at the left side of this graph, where it's greater than 25.6 nanometers, which is the peak particle diameter for the LDL. If your ApoB is low, at less than 120, your risk is 1.0. If it's greater than 120, your risk doubles to 2.0. So it's still much better than if your LDL peak particle diameter is lower and you have the small dense LDL. But according to this, the large LDL size does matter. Now, that goes against a slide like this. So what do you do when you have conflicting data? Well, the first thing you do is you don't make sweeping conclusions. Based on this, I could not say that large, less dense LDL is not harmful at all. But in the right situation, it's certainly less harmful. And, what was the inflammatory markers on these people? What kind of diet were they eating? What was their glucose and their insulin, right? We don't know the answers to all those questions. But so I agree. And again, this is where I get into trouble with the low carb community. I agree that that's a better situation to be in, but I just have asked people to have pause to not make it overly simplistic. Now, this may be the response. Luckily, I'm not there in person for you guys to throw eggs at me. Hopefully, they'd be free-range, pasture-raised chickens for those eggs. But before you throw eggs at me, just realize the point of this is to not make things overly simplistic, okay? We have to take population-based data and filter it down to individual people. And yes, we have had an over-reliance on LDL, which has taken us away from the focus of the metabolic health, which has hurt us more than it's helped us. But we have to be careful and make sure that the strength of our message is matched by the strength of the evidence. And especially if we want to have discussions with cardiologists and physicians and endocrinologists and further discussion of low carb in the medical community, I think we have to keep that message in place that yes, LDL matters less, but let's not make it too simplistic and just do the opposite of what we've already done of making it too simplistic, saying that LDL is the only thing that matters. We can't make it too simplistic and say LDL never matters. But what we can do is talk about other risk factors too. So one more I want to talk about is the new kid on the block. And I'm not talking about these new kids on the block because let's face it, they're not so new. They're not so young anymore, but neither is lipoprotein a. And this is a diagram by Siobhan Huggins, sort of the new kid on the block for cardiovascular risk. It looks just like an LDL. It's got cholesterol and triglycerides. It has an ApoB 100 on it, but it also has this kringle, and it's got this ApoA, which alters it enough that it's taken up by scavenger receptors. It's more likely to be oxidized, more likely to actually help form clots. And according to this, again, that same European Society of Cardiology paper, if you look at the top, it shows you the increased risk of elevated LDL in observational and genetic trials. And you can see down on the bottom there for lipoprotein a, it's the same, if not greater, than the risk of LDL. So the observational studies show that lipoprotein a is as big of a risk, if not bigger. And one of the reasons why we haven't heard a lot about it is because here are the approved drugs for elevated LP(a). That's it. No other slide. There are no approved drugs. It's a drug-free zone. Now, PCSK9 inhibitors can decrease them by 15-20%. Niacin can decrease it a little bit. Vitamin C, L-carnitine, proline, lysine, those can decrease them a little bit, but there are no approved drugs. But there are drugs coming on the horizon, these antisense RNA inhibitors that are a whole brand new class of drugs that can lower lipoprotein a by 80%. And that's, I think, personally, why we're hearing so much about it. But regardless, it's a good thing because it adds one more risk factor. So again, if you want to say I'm a hyper-responder, I don't have to worry about my risk, well, this is something you need to know. You need to know your LP(a). And then, of course, coronary calcium score, which we hear a lot about. And thankfully, the 2018 guidelines now say coronary calciums should be in the cholesterol workup guideline, especially for those for intermediate risk, because we know with a score of 0 now for these trials out to 10 years and now a recent one out to 12 years, there's really no increased risk for cardiovascular disease and no statin benefit with a calcium score of 0 for the people included in this study. So in summary, cardiovascular risk assessment on a low carb lifestyle, ApoB, probably the best one, better than LDL-C or LDL-P. Small dense LDL, something you definitely want to know, the ApoB to A1 ratio, the triglyceride to HDL ratio, inflammatory marker like the CRP, lipoprotein(a), and the calcium score. And of course, don't forget the power of a healthy lifestyle. We talk so much about nutrition, which is important, but physical activity, sleep, stress, social connections all play into a healthy lifestyle. And so as clinicians and as individuals, we don't have to be confronted with this would you rather. Would you rather have metabolic health and feel good and reduce your hunger, or have normal LDL cholesterol? The vast majority of the time, we don't even have to consider that, especially if we're focusing on providing patients and providing ourselves with the lifestyles we need to live the most vibrant and happiest lives that we can. And that addresses our hunger, that addresses our cravings, it addresses our energy, and addresses the whole picture, not just of cardiovascular risk, but of life enjoyment. Thank you very much.